Move on to our second presentation, so Dr. Suzanne Dyer. So Sue's a Senior Research Fellow at Flinders University. She's worked as a researcher in both the public and private sector with expertise in evidence-based methodologies, including health technology assessment, systematic reviews, meta-analysis and guideline development. She's the author of over 70 publications and reports, including the Cochrane Review on Interventions for Improving Mobility After Hip Fracture. So very much a focus of this session this morning is how do we get the best functional recovery after a hip fracture. So welcome, Sue.
Thank you. Thanks very much. So this morning I'm going to be talking to you about what the evidence says for rehabilitation for recovery from hip fracture based on 3 Cochrane reviews. And so we all know that surgery to treat hip fracture is generally very successful, but as we've heard from Louise, few people actually then fully recover. So many survivors don't fully regain their mobility, over half will fall again in the next year, and many become more dependent and don't return to their pre-fracture residence. So interventions that can improve mobility and reduce falls after hip fracture are obviously really important. So today I'm mostly going to be talking about the findings of the 6th update of a Cochrane review, which examines interventions for improving mobility after hip fracture. This was published last year and Nikki Fairhall led this review that I worked on as well. The review was initially published in 2003, simply examining early versus delayed weight bearing after surgery and included only 4 trials. The most recent update now includes 40 trials and includes conclusions based on the benefit of rehabilitation interventions. I'm briefly going to touch on a couple of other Cochrane reviews. So one of these is multidisciplinary rehab for older people following hip fracture, and also a Cochrane review of enhanced rehabilitation of care models for people with dementia. Now, Cochrane reviews are really highly rigorous. It's a huge amount of work goes into them with a lot of authors, and they're considered the gold standard of systematic reviews. Now, all Cochrane reviews use the grade approach to rate the certainty of the evidence of the findings, and this gives a judgment of how much confidence we've got in the results of the review. So we're using a stoplight system here to make it simple, but if you've got high certainty of evidence, we can have a lot of confidence in these findings of the review, and we really should be going ahead and implementing these approaches. At the other end of the spectrum, if there's very low certainty evidence for a particular finding in the review, we're quite unsure if those results are true. They could change with more trials or over time. Now, the reviews themselves don't include clinical recommendations from the author's viewpoints, but I'll add in just a few thoughts from my co-authors who are clinicians, although I myself aren't. Now, all of these reviews looked at in-hospital and post-discharge settings separately. So for each, I'll talk about the in-hospital interventions first and then move on to what happens after discharge. So the first review of mobility interventions included randomised controlled trials of adults who've had hip fracture surgery in the previous year. The interventions are mobilisation strategies. So those are things that aim to increase mobility, such as electrical stimulation of the muscles, various forms of exercise, and also care programs such as immediate versus delayed weight bearing. We included trials where the intervention was compared to usual care in the in-hospital setting, or after discharge compared to usual care, no intervention or intention control, or a sham. And this review examined a range of important outcomes that you can see on the right there, particularly mobility. So here's a summary of the trials and patients that are captured by each of the 3 reviews. And you can see for the first review that I'm going to be talking about, which is interventions to increase mobility, there were 40 included trials that captured more than 4,000 patients. 18 trials were conducted in hospital, with 7 in orthopaedic wards and 10 conducted in rehabilitation wards. And 22 trials were examining outcomes after discharge. Now, if we look at the findings from this review, we actually found low certainty evidence that there was clinically and statistically significant improvement in mobility for mobility interventions delivered in hospital. There was also moderate certainty evidence that these interventions overall, when pooled in a meta-analysis, can increase walking speed. However, for this, the confidence interval did include the possibility of a slight decrease in walking speed. The review of in-hospital mobilisation interventions showed no effect on mortality, readmission or returning home after discharge, but this was just based on low certainty evidence. And overall, we were uncertain of the effect on functioning and health-related quality of life because there was very low certainty of evidence. But note for some of these outcomes, there's far fewer trials that actually measured these outcomes. Now, it's really difficult to determine which elements of the intervention make it effective. The trials are really complex and different, so that's very difficult to do. So I can just really talk about the components of the interventions of the trials that were captured. So overall, of the 18 trials conducted in hospital, 3 examined electrical stimulation, but none of these actually measured mobility outcomes. Most of the trials looked at gait, balance and functional exercises. So these are exercises focused on mobility, balance and transfers, and also task-specific strengthening exercises where resistance is added to functional tasks like sit to stand or stepping using body weights or weight vests. 3 studies were conducted in rehabilitation wards and examined progressive resistance training. Now, this is progressive resistance exercise to strengthen a specific muscle using low repetitions and high load. So if we look at the effect of the different types of exercise interventions on the mobility outcome, there was clinically meaningful improvement in mobility from gait, balance and functional training based on moderate certainty evidence. So we can have reasonable confidence in this. And this was based on pooled evidence from 6 trials. There was a single trial that examined progressive resistance training in a rehabilitation ward, and that showed little or no difference in mobility, but that was based on low certainty evidence. And unfortunately, in the in-hospital setting, there were no studies of other types of exercise, so that were primarily flexibility, 3D, exercise like Tai Chi, endurance, general physical activity, and the electrical stimulation studies did not look at the mobility outcome. Now, because it's so difficult to tell you what particular elements of the intervention are effective, what we can do is focus on the 3 trials of gait, balance and functional exercise, which we know has good evidence for improving outcomes. And I can tell you a little bit about what interventions were used in these trials. So these effective studies really focused on providing exercise as early and intensively as possible. So intensity was really the key in the Australian effective trial, Hips for Hips. So this compared 3 times daily physio to once a day and actually caused a 10-day reduction in length of stay. So there was a lot of additional physiotherapy. Intensity was also the focus of effective studies conducted in Italy and South Korea. Now you can see that of the first 2 of these 3 studies, there was a focus on mobility, balance and transfers, as well as task-specific strengthening, while the last study added treadmill training. Now, if we consider the studies conducted after discharge in the post-hospital setting, there were 22 trials. 3 were in the outpatient setting, but most were in the community and people's own homes. And what we found when we pooled the results of all these trials in meta-analysis was that we had statistically and clinically meaningful improvement in outcomes of mobility and walking speed by providing mobility interventions after discharge. And this is based on high certainty evidence. The interventions also resulted in a 21% reduction in the rate of falls with moderate certainty evidence. So this is obviously a really important outcome as well. There was a very small and statistically significant improvement in functioning and health-related quality of life. These improvements might be so small they're not clinically meaningful, but it's certainly an indication that we're moving in the right direction in terms of these interventions. And there was low certainty evidence of no effect on mortality or readmission. So again, we've got some good quality evidence for improvement in the mobility and walking speed outcomes. So let's look at what type of exercise interventions were provided in these trials. So again, most trials provided primarily gait balance and functional training. 5 studies involved progressive resistance exercise, and 5 studies combined these 2 types of exercise. So if we have a look at the effects of the different types of exercise and mobility interventions, we can see that gait balance and functional training, again, improved mobility with high certainty of evidence. And this is from pooling the results of 9 different trials in a meta-analysis. Resistance or progressive resistance and strength training also improved mobility, but with low certainty evidence. And when we combine the 2 types of interventions, we've got moderate certainty that we can improve mobility when we're delivering this after discharge from hospital. The impact of aerobic training was unclear, but this is based on only a single trial. So if we look at some of the other outcomes, mobility interventions also improve strength when delivered after hospital, so strength of the lower limb, and this is based on high certainty evidence. Mobility interventions might also improve sit to stand, but there was no evidence of an improvement on a range of other outcomes, balance, walking aid use, activities of daily living and self-reported lower limb function. So again, it's difficult to know exactly what elements of these interventions are driving the improvement, but we've got high certainty evidence that gait balance and functional training can improve outcomes, and also that adding some strength training can improve that. So let's look at the types of interventions that were provided in the trials that did achieve these effective outcomes. So again, it was intensity that's really important in these trials. And in general, several of these trials were delivering exercise in small group exercise classes. Or they were delivered in the home with a physiotherapy home visit and interventions to increase adherence beyond that, say providing a DVD. So the delivery of these programs is actually quite intensive in terms of providing interventions in the home, and this might be a challenge in many settings where resources are pretty limited. These studies included balance and gait training, and also a strength training component, which was task-related strengthening or progressive resistance training of specific muscles. Now, I'll just quickly touch on the Cochrane Review of Multidisciplinary Rehabilitation. So this review considered interventions where rehab was provided by a multidisciplinary team, supervised by a geriatrician, a rehabilitation or other physician, as compared to usual care. And usual care was that provided by an orthopaedic or medical team generally. So in early studies, this is care in the orthopaedic surgical ward, and in some of the more recent studies, it's an alternative rehab program which might be started later and is less intensive or coordinated. And the primary outcome of this review was a composite poor outcome considering mortality and decline in residential status at 6 to 12 months follow-up, so considering long-term follow-up. In this review, there were 28 included trials with more than 5,000 patients. 21 trials were conducted in the hospital setting and 7 following discharge, including Maria Crotty's Sacred trial, which was conducted in a nursing home setting. So if we look at the effectiveness of multidisciplinary rehab provided in hospital, we've got moderate certainty evidence that that can reduce the chance of a poor outcome at long-term follow-up. And there was low certainty evidence of a reduction in death, although again this confidence interval slightly overlaps one, so that's not completely significant, and low certainty evidence that it can improve mobility. Now in this review there were only 7 trials conducted after discharge in the home and community setting, and data could only be pulled for 3 of the trials, so unfortunately there was very low certainty evidence of the effect of post-discharge multidisciplinary rehab on the outcomes, and they showed little or no treatment effect, but we can't be certain of whether that effect is true or not. Now, finally, looking at important review of rehabilitation, enhanced rehabilitation strategies for people living with dementia. Now, as more than 40% of people who fracture their hip have dementia or cognitive impairment, this was an important review to do, and the intent was to include trials that examine enhanced rehabilitation strategies for this population, but also subgroups of patients within broader reviews that had provided rehab to all older people, and then looking at the effectiveness of those strategies for people living with dementia. Now, unfortunately, this review was quite disappointing, I have to say, which is because there were only 7 trials that met the inclusion for the review with 555 patients, and you can see the risk of bias of these trials for this particular population was considered really high, and so there wasn't a lot of quality evidence. Now, as I said, the aim was to look at enhanced rehabilitation strategies specifically designed for people with dementia, and there were no trials at all considering this type of approach. The 7 trials included were actually just reporting on the subgroup of people with dementia or cognitive impairment within a larger trial delivering enhanced rehabilitation to all older people. And then within that 7, 3 were conducted in the inpatient setting, 2 were delivered inpatient and in the community, and 2 compared geriatrician-led care to an orthopaedic team-led care. So unfortunately, because of the quality of the trials, the fact that they were very diverse in what they were examining, again, we only had very low certainty evidence for all of these, and no really clear conclusions could be drawn from this review. So this is a really important area where more research needs to be conducted. So I'll just really quickly recap on what we've got strong confidence in, and this is what we should really be concentrating on. So within the hospital, we've got moderate certainty evidence that mobility increases walking speed, gait balance and functional training improves mobility, and multidisciplinary rehab can reduce poor outcomes. So we really should be implementing this. And after discharge from hospital, mostly in the community, we've got really high certainty evidence that mobility interventions can improve mobility, gait speed and strength, and that gait balance and functional training in particular can improve mobility. And moderate certainty evidence that we can improve other outcomes with these mobility interventions, and that when we add strength training to the gait balance and functional training, we can also perhaps get improvements in mobility. But moving forward, there's obviously a lot of work still to do. We really, really need trials of enhanced rehabilitation strategies that are designed to deliver rehab to people with cognitive impairment and dementia. We've got strong evidence that exercise interventions can improve the outcomes, and so we really need to be implementing and evaluating these exercise interventions. And we need to do more work on determining which are the most effective types of interventions, using both further different analyses and new trials, but particularly regarding what types of interventions might be able to be implemented in more low resource settings that perhaps are going to be more achievable than these really high intensity. And that is likely to be very cost effective if we can do that. So I'd like to acknowledge my co-authors from the University of Sydney, particularly Nikki Fairhall and Kathy Sherrington, and my funding provided from the Falls Prevention CRE. Thank you.